Good morning, everyone, and welcome to the third of our panels in what has been a thoroughly thought-provoking seminar series on the broad topic of technology and the world around us, hosted by the Centre for Artificial Intelligence and Digital Ethics, CADE. This is the third panel in our series. In prior months, we've already heard from speakers on topics ranging from art, literature, and artificial intelligence, and most recently, animals, ethics and technology, the recordings of which are all available on the CADE website. Before I introduce myself, it's important that I acknowledge that I'm joining you from the traditional lands of the Wurundjeri people of the Kulin Nation today. I pay my respects to Wurundjeri elders past and present. And I acknowledge that these lands are stolen and sovereignty of them has never been ceded. I also acknowledge the injustices that Aboriginal and Torres Strait Islander people face on their lands under the continuing effects of colonisation. My name is Tyne Sumner and I'm your host for this morning's panel. I'm a postdoctoral researcher in the School of Culture and Communication, as well as a researcher with CADE, where I work on surveillance, digital ethics, and translational and interdisciplinary research that bridges the humanities with STEM and data-centric fields. I'm delighted to have our three amazing panelists here today who are speaking to the challenges of automated decision-making in healthcare. The first, Professor Wendy Chapman, is the Associate Dean of Digital Health and Informatics and the Director of the Centre for Digital Transformation of Health, with whom this panel is co-hosted today. Wendy's interests include biomedical informatics, natural language processing, knowledge representation, and the application of informatics to clinical care and research. She is an elected fellow of the American College of Medical Informatics and the US National Academy of Medicine. After Wendy, we'll hear from Dr. Daniel Capurro, who is a senior lecturer in digital health and deputy director of the Centre for the Digital Transformation of Health. Daniel holds a PhD in biomedical and health informatics and is primarily interested in developing methods to improve the use of clinical data for research. This includes the use of electronic health records and the data collected in them. Daniel has extensive applied experience in health informatics and was the Chief Medical Information Officer for Chile's Catholic University Healthcare Network. Our third panelist this morning will be Professor Uwe Aickelin, who is the head of the School of Computing and Information Systems. Uwe's research focuses on artificial intelligence, optimization, and data mining for medicine. He has been Vice President of the University of Nottingham, Ningbo, China, and served as a strategic advisor for artificial intelligence to the UK Research Councils and government. In terms of housekeeping for our panel today, each speaker will present for about 10 minutes with some short questions and discussion in between. However, we'll go to a general Q&A at the end. So as we move along through our panel, please add your questions to the Q&A chat box, which I will monitor so that I can direct your questions to our speakers at the end. Before I throw to Wendy though, and in the interdisciplinary spirit of CADE, I want to start our discussion with perhaps something a bit unexpected, and that is to start with something from the world of literature. Many of you will be familiar with the English author Mary Shelley's 1818 tale of Frankenstein, the modern Prometheus, a novel that still to this day comments on the advancements in medicine, science, and health technologies, especially now with the advent of artificial intelligence into healthcare and health sciences. In this famous text, Shelley tells the story of Victor Frankenstein, a young scientist who creates an intelligent creature in an unorthodox scientific experiment, but things go terribly wrong. And here are two short quotes from the novel. "So much has been done," exclaimed the soul of Frankenstein. "More, far more will I achieve, treading in the steps already marked. I will pioneer a new way, explore unknown powers, and unfold to the world the deepest mysteries of creation." Here, early in chapter 3, Victor Frankenstein displays an almost godlike complex in his quest for forbidden knowledge, deciding to go beyond the limits of science to understand how life is created. But then later in the story, he begins to realize the dangers of taking science too far, playing with God and with life and death, when he sees the kind of monster he has created, and he declares, "I beheld the wretch, the miserable monster whom I had created." So I'm starting with Frankenstein for our panel today because this novel eerily predicts some of the ethical dilemmas that our speakers will comment on. As technologies in the healthcare sector become more advanced, new questions are emerging about their deployment, development, and use in a wide range of contexts. These technologies have the potential to aid incredible leaps and bounds in healthcare, but we want to think about who is making the decisions about treatment and medicine, and who is responsible for the decisions made by automated systems. To think through these questions, we must first understand how these technologies work before turning to challenges and questions of accountability. To get us thinking about the long and complex history of automated decision-making in health and the ethical issues relating to advancements in data use, I will now hand over to our first speaker, number 1, Wendy. Thank you.
Thank you, Tyne. Right. Okay, it's a pleasure to be here, and I've had a lot of fun thinking about this talk and the message that I wanted to bring. And so my title's a little long, but I wanted to start with a little bit of history and to make it personal, because this is the history of computerized medical decision-making, but it also is, you'll find out how it's personal with me. Okay, so the first paper on this topic was in 1959 by Ludley and Lusted, and it was a conceptual paper about how we could use mathematics to really help reason and do automated medical diagnosis. And they presented a table where you had the diseases as rows and you had the symptoms as columns, and you could now create probabilities for those, and that could be used to help with automated decision making. Homer Warner is the first person that picked that up and made it more practical, and he has a long history. In the early 50s, he was a cardiologist, opened the first catheterization lab at a hospital in Utah called LDS Hospital. Worked on one of the first analog computers there, and started to publish papers in circulation, modeling circulation. And then what he did is he published a paper in 1959, so 2 years after the Ludley and Lusted paper. And this paper was applying that idea to congenital heart disease. And because he had a lot of patients with congenital heart diseases coming through his laboratory, they decided to make a probabilistic model to diagnose patients with one of 35 different forms of congenital heart disease. And so he took that idea of the table with the diseases and the symptoms, and they tracked 1,000 patients and filled in the probabilities, and then created a Bayesian model to diagnose patients. And they compared, they used real data, real patients, and they compared the computer diagnosis against the diagnosis of the referring physician, and found that the computer was right more often than the referring physicians. Now that caused a lot of surprise, but the average physician only saw 2 or 3 patients with congenital heart disease a year, and so didn't have the experience that the computer had in the prevalence. Now he popped up in a book that I just listened to on recommendation from my husband, Brian, The Theory That Would Not Die, about Bayes' rule and the history of it. And so it's notable because at this time in 1961, Bayesian mathematics was still not very accepted in most places. But that he was noted here and used it on these children. And the quote that old cardiologists just couldn't believe that a computer could do something better than a human. Well, on the right is the Ludley and Lusted article, and how that was the seminal article that spawned a lot of different work. But you'll see Homer Warner's article is actually one of 2 that came out of the Ludley and Lusted article. And it's cited as one of the crucial reports that led to the development of this new field of investigation automated medical decision-making and what became informatics. So in the catheterization lab, Homer began collecting and displaying data. And so on the left side is you've got a catheter inside someone's vein, and it's measuring continuously their blood pressure and showing that. And so the goal was really to start collecting data and displaying data for clinicians to help them make better decisions. Well, one day he went down to visit the ICU, and there was a nurse who was standing over one of the beds pumping up a blood pressure cuff. And there was a catheter in the artery. There was a yellow light on the panel indicating that something was wrong. She was very embarrassed when she saw him watching her, and she explained that she knew that it was telling her something was wrong, but she didn't know what to do next. She didn't know what was wrong or what to do. And so they sat down and they talked about it, and they brought in a resident, and they decided that the patient probably was having a cardiac tamponade. And so they called the surgeon and took the patient back to the operating room. And this was a turning point for Homer, because he realized that more data is not necessarily what people needed. They needed to have intelligence in the system to help guide them, to help them interpret the data and know what to do, because that's what they're making decisions about. So to do that, he went and presented some papers at a conference in Europe. And while he was there, he had 10 days between his two meetings. And he was at a little hotel overlooking Lake Geneva. And he got the idea to create a computer representation of data that you could now leverage to really help make decisions and provide support to clinicians. And that system is called the HELP system, because it's giving the care provider assistance. And that system generated alerts, reminders, messages to increase adherence to protocols and standards of care, to improve differential diagnosis and suggest therapeutic interventions. So that was installed in the early 70s and was just replaced about 2 years ago with Cerner, a vendor system. In addition to the EMR, building that, he would also, was very passionate about Bayesian diagnostics. And so he developed a system called Iliad. Homer's Iliad. And Iliad utilizes a number of inferencing mechanisms to mimic the strategy of a medical expert in working on a patient. And so users would enter clinical findings about a case, and the system would generate a rank-ordered list of diagnostic hypotheses using Bayesian probabilities and expert opinion that was built into the priors. And so his goal was to help in diagnosis, and ended up being a tool for training people. But this room where they're sitting, this is in the early 80s. Everyone didn't have their own computer or their own laptops. And so there were computers all around this table and glass on top so that you could see it. And this was called the knowledge engineering room. And this is where I trained as in my PhD in medical informatics. I stood up at that whiteboard and defended became a PhD student after my exam, and had journal clubs, and this room was everything in my training. So that's where it becomes personal. Homer was the chair of the department when I first arrived, and I ultimately replaced him as the fourth chair of the Department of Biomedical Informatics at the University of Utah. Well, people came from around the world to work with Homer and built new automated decision support systems. I was in a lobby of a hotel in San Francisco, and Kaz Kulikowski, who I didn't know, came up to me and said, "Oh, you're the new chair at Utah. I went to Salt Lake to learn from Homer in 1968. And a lot of people came up to me and said that. A colleague of mine, Dominic Oronsky, came from Switzerland to build decision support that he could implement that would update the probabilities of pneumonia based on new data. And it even, that's me on the left with my colleague Marcelo. And my first paper that I ever published was in AMIA, and it was Bayesian modeling for linking causally related observations in narrative chest X-ray reports. So this whole idea of Bayesian decision-making infiltrated through. Homer died in 2012, and I really like this quote about the mind of an intellectual and the soul of an adventurer. And so I want to just kind of conclude with, data is really the foundation of this, and intelligence that comes from data. But I want to talk about 4 points that illustrate this maxim that my colleague, mathematician Fred Adler, said: data is where models go to die. So 4 examples. 1, we encode bias through our collection of data. And most people probably know about all kinds of examples where we've trained our artificial intelligence or other applications on data that's collected from a subset of people that's not representative of the population. And so pulse oximetry, for example, performs more poorly on darker skin pigmentations. And that has an effect in COVID of referring people to the ICU or putting them into the ICU or the hospital later because it's not accurate. A second area is that we're encoding the physician biases in the data that we're using as our gold standard. And so we're using what happened in the past as what should happen in the future. But what's happening in the past is that we're all biased people, and underserved populations, and in the US especially, people of color, receive worse care. And this is an example where if you use the standard measures of the severity of pain, knee pain, that the physician's decision accounts for about 9% of the racial disparities. But what they did is they used artificial intelligence and they trained it on the image itself, and they trained it on the patient description instead of on the physician's grading of the pain, and that accounted for 43%. So artificial intelligence can encode biases, but it can also help decode them. The third area is the area of dark data, and that's the data that we don't collect, but it may be more important than the data that we do collect. An example of that, and this is my interpretation of this, Raymond Hu at the Austin, has found that post-surgical prolonged apnea events predict complications, but they're only measuring they're only measuring this at 30-minute intervals. And so they're not capturing it. So what we're not measuring is often what we need. And the fourth is that, a major reason the Iliad and other medical decision-making, especially diagnostic tools, have not been successful in the real world, even though they're successful in the lab, is that you have to enter the data by hand. And when that, or you have to go to a different website in today's world. When that happens, people don't use it. And so Daniel's going to tell us more about how implementing these in practice makes a really big difference to whether or not they'll succeed.
Wonderful. Thank you so much, Wendy. I feel as though we canvassed an incredibly long history in a very short and complex history in a short amount of time there. So thank you for introducing our topic in that way. And I was also struck by the Iliad as a name for this project and its related activities, and thinking about the relationship between the Iliad as an epic and its understanding of time and accomplishment, and also pride, and the extent to which investment in particular medical technologies brings with it a certain amount of pride that may be a barrier to the collection of data and the ways in which biases remain unexposed. You spoke a lot about the extent to which we encode bias through data collection. And before we move on to Daniel, I wonder if you wanted to speak just a little bit more about potentially, generally speaking, any of the steps that are being taken to counteract some of the biases that you pointed out.
Yeah, thank you. I think there are a lot of steps that are being taken, just being aware of it. I know that there are some new guidelines that are being put out by the National Institutes of Health in the US. And also they're investing quite a bit of funding in their new strategic plan to really help create better methodologies for getting more diverse data. And it's not just a matter of knowing, oh, I need more diverse data. There are reasons that we're not capturing that data. And some of them are easily solvable by just looking harder, but some of them are really difficult because you've got communities that don't trust the healthcare system and have been, for good reasons. And so, and are not always willing to participate in research. But there are programs to try to, where people can, to collect more diverse data and more requirements. And then there are also, I think, some, computational methods for adjusting for poor sampling.
Great, thank you. And I can see we have some comments in the chat. A reminder on that point to put any questions you have that we can go to at the end in the Q&A box down the bottom. From Wendy, I will now hand over to Daniel, who's going to pick up on some of those key points, but also speak a little bit about some of the effects that we expect to see through automation, and also some of the challenges around implementation of different tools, data and methods. Thanks, Daniel.
Thank you, Tyne. Let me share my screen. All right. So thanks for the opportunity. This is a very exciting discussion. And I will just use these slides to sort of inspire the discussion that I hope we will be having later. So I just wanted to pass 3 messages after Wendy's discussion. The first one is that in medicine and in healthcare, classifications or diagnoses have implicit follow-up decisions. And that's one of the main drivers, I would say, of unintended consequences of automated decisions. And why? Because if you, for some reason, you decide to order a chest X-ray to a patient, and you find what I hope you can see there is in that black square, a nodule in the patient's lung. It's nearly impossible that you will decide not to do anything with that. So even if you think that it's an artifact in the technique, even if you think that the radiologist might have made a mistake, it's almost zero chance that you will not follow that up. And that normally involves new tests, surgeries, biopsies, and even labeling a patient as having a nodule, and that the downstream consequences that might bring. So when you think about this, and we're designing these algorithms that Wendy was describing, that help us create lists of likelihoods of diseases. If you have whatever data, ideally unbiased data that is processed by a machine learning algorithm that you have trained on this data and tells you that there's a likelihood that this patient has a risk of lung cancer, there's almost zero chance that as a clinician you will just stop there thinking, oh, this may be a false positive. You're probably going to do a bunch of other things, and that's one of the I would say risks that we might see emerging these days when we start applying these new algorithms to diagnose conditions. And I think there are 2 very strong forces that are contributing to this. And we are having a lot of data coming in the form of electronic health records, but also in terms of smartphones, other smart devices, sensors, and so on. And we also have, we're getting very good at developing new algorithms that allow us to classify and predict what might happen with these patients later on. So again, these 2 blue things, we're getting very good at it. So the consequences of not just automated decision, but implicit decisions is going to be a big problem. And we need to start considering the size of that problem when we start deploying these algorithms. One example of this, and this is not just specific for artificial intelligence decision making. Any diagnostic test has that risk. But again, when it's so easy to get access to large amounts of data and very powerful algorithms, then it's easy to deploy, like Apple did, for example, an algorithm to identify arrhythmias in 500,000 young patients in the US. So then, what are the consequences of that? We don't really know. The second one is, what is the pathway to implementation? And again, the core issue here is that we are getting very good at generating algorithms that are very accurate and even better than clinicians at deciding, whether a patient has a condition or is at risk of developing a condition in the future. Again, we're getting very good at that. But when you start thinking that, somebody needs to collect this data to generate, a prediction of a risk, of diagnostics, or a recommendation, and then presenting that to clinicians so they can action on that information. On the left side, you can see that collecting the right amount of data takes time. For anyone that has worked in a machine learning project in healthcare, probably 80% of our time is spent sort of cleaning up the data, making sure that it's the right type of data, that we're not having, dirty data, biased data, and so on. But then when the time comes to deploy these algorithms, you need to go back to the dark reality that data is messy at the source. So how do you account for that, the problem of having, dirty, incomplete data from the very beginning? And on the other hand, let's say we have great data coming in real time. We have a great algorithm that classifies my patients, correctly. But you need to sort of execute that recommendation in some way or form. And this normally comes in the way of alerts, messages, red flags popping up in a clinician's electronic medical record. But we now know with a lot of certainty that doctors tend to ignore, 80% of those notifications. And why do they ignore them? Well, because we get too many. There's this phenomenon called alert fatigue. So again, there's a big challenge on how do you transform this, this risk measurement, prognosis, recommendation into an action. And we still haven't figured out what are the best ways of doing that. We know that we can nudge doctors into doing better things, but having a good effector of these recommendations is still an area of uncertainty. One case of where a very huge company with a lot of, the brightest people, failed at this pipeline is the example of what happened with Watson Oncology. So Watson is a product by IBM, one of the most powerful supercomputers, and became very famous when it started using natural language processing, and it beat a lot of very high competitors in the game of Jeopardy in the US. And then so the next big thing was let's fix healthcare using Watson Health. And after many millions of dollars and human hours, then IBM decided to scrape that project and focus on automating simpler situations, again because they faced this problem of translating the data to a recommendation and a recommendation to an action. And the third one is, will my patients or clinicians or the healthcare system be better off? And most of the time, we don't know that yet. And that involves the need for extensive validation, and validation not just in my own data set that I spend months cleaning, but in real world settings. And also clinical trials for effectiveness. Because again, here we have spent the last year discussing about vaccines and which vaccines are in phase 1, 2, 3, and 4, and approval and adverse events. So we're pretty much becoming experts in understanding that healthcare interventions have benefits and may have risks, and we need to make decisions. And the same thing needs to apply for automated decision in healthcare. There's one article that this is remarkable. It was published last week in I think in the Lancet, and this is I would say the largest validation study that I have seen of an AI algorithm to classify retinal images to find retinal diseases. They used 200,000 patients to train their model, but they validated in 18,000 photographs from 35 different hospitals in different locations in China. And then they did a final validation in 16,000 photographs from the USA, where the majority of the patients were of very, diverse racial mix. So this is, again, speaks to this need for extensive validation. So this algorithm is probably way more robust in terms of clinical performance than one that hasn't gone through this process. But it's still missing a part. We don't know whether patients are better off. That's the second question. Will my patients be better off? And this is where we need to draw this parallel between the drug or device or vaccine development pipeline, where you have a stage where, discover and develop the product, do the preclinical research, and then the clinical research. We don't have that for digital health interventions. And in AI, machine learning algorithms are a type of digital health interventions. So we need to move forward and advance this idea that they need to be, just like any drug, just like any device, they need to be tested and validated and demonstrate patient benefit so we can safely be sure that it's a good choice to adopt them. And that's it. Thank you.
Thank you, Daniel. That was fantastic. And I will, if Wendy or Uwe, you want to jump in and make any comments or reflections on the second piece there, by all means, please do so. But I will actually just note, Daniel, that you, in teasing out a lot of those tensions, really drew our attention to the way that many of the algorithms you spoke about are getting increasingly accurate. And you mentioned too that they are therefore in some cases even better than clinicians. And so I wonder, just as a follow-up, if you could speak to this tension and this idea of whether this in fact poses a genuine threat to the medical community, whether there is perhaps a tipping point of some sort in which it is decided that the algorithmic processes are more accurate. And if so, are there any formal decision-making processes or protocols or procedures in place to decide when it's appropriate for the algorithm to, I suppose, supersede human decision-making, or is that further on the horizon?
So I think there's two components of your question. The first one is, is there a risk for the medical profession? And I think we can also look at history and to see, what happened here. The medical profession was very, scared when the first stethoscopes came to be. And there's interesting papers about the discussion that, this will kill the profession because now you don't have, this human touch of, feeling. Doctors used to put their ears towards a patient's chest to listen to their lungs. And there was was taught as a technique in medical schools. And of course, now nobody does that. And we learn how to use these different instruments. Same thing with imaging and so on. And the second, historical piece is what happened with chess. The first time that the, world, grandmaster of chess lost to a supercomputer, which, happened to be IBM again, the world champion was devastated, and he said, what's going to be about this game? And now we see that there's championships of grandmasters that are supported by supercomputers, and they're a new category of championships. So I think it challenges the way we do things, but it opens up new ways of doing things. And Charles Friedman, he's one of the big thinkers behind medical informatics, and his fundamental theorem is that in medical informatics, the human needs to perform better, supported by the computer than the human alone. So now we're seeing algorithms that perform better than clinicians. And again, those are clinicians without the algorithm. So now we need to figure out, what's the best way? Is it just a computer superseding what the doctor is saying in isolation? Or is it better to have the computer supporting a clinician making that decision? So I think there's still questions that are open for discussion.
Fantastic, thank you. And I can see in the chat the issue of context is pretty primary in the comments people are making. We have a couple of questions for you in the other Q&A, but I'll leave those to the end for the whole panel and hand over now to you, Uwe. Thank you.
Hello, everybody. Thank you. for my turn. I don't have any slides. I basically just want to talk a little bit about fairness, but maybe not in the way you expect me to talk about it, but let me explain. So first of all, how do most AI algorithms work? How does machine learning work? Well, the idea is that we have some inputs and we can predict an output. So for example, we have some biological markers and the output would be, yes, you have cancer, or no, you don't have cancer. Or maybe it would be cancer type 1, cancer type 2, type 3, type 4. That's a very typical machine learning system. And in the middle might be a big neural network or a Bayesian algorithm or something like this. Now, the problem I have with this approach is that if you actually talk to human doctors, they very often are not sure what is the problem. And it is the human doctors in the end who give you the gold standard marker. So the data we have, which has labels like, oh yeah, it's cancer type 2 or cancer type 3. Ultimately, these labels come from humans, but the humans aren't sure sometimes. And I don't know if you notice from your own doctors when you talk to them, they also change their mind. We have done studies with doctors where we give them a set of data. We ask, what do you think? And they give you an answer. And then a month later, we come back with exactly the same data and we say, what do you think? And they give you a different answer. So different experts give you different answers. Even the same experts can give you a different answer at a different time. And that's human nature. We're not always sure. We learn new things, or we interpret the data differently, or maybe it depends on our breakfast in the morning. There's all sorts going on, right? So we live in this world of uncertainty, basically. And I'm now thinking, okay, that gives me two questions. When we implement the AI algorithms, the machine learning, there's a technical question. How do we handle this uncertainty? And I don't really want to talk about that now, but if anybody has any questions about that, I'll be happy to answer. That's a lot of my research is in this area, technical aspects. What I really want to come to is something else, which is, so let's assume we have a machine learning algorithm and it performs on some data set and it comes up with some answers. But how do we actually now fairly evaluate these answers? And I mean, fair to the AI, not fair to the human now. I want to get a fair assessment of the AI. Now, it might get some things wrong, but that's because the human experts also didn't know the answer. Or actually, the answer is indeterminate. It cannot be determined. Nobody knows the answer. And ultimately, I'm asking this question not because I care much about the AI. I do care about the AI. I care about the person creating the AI, which might be me. So how do you fairly judge my work if I get some answers wrong, but the human experts couldn't even agree what the answer was? So that's really what I want to say. And I'm happy for you to challenge me on this or give me some ideas. What's fair? How do we do this fairly?
Thank you. Very thought-provoking. I feel as though this panel could go for 5 hours just on that question alone, Uwe. But there is one actually in the chat that links very much to what you were just speaking to. And I'll put this to the entire panel. And the first question in relation to the general field of decision-making in health is, how important is empathy for reviewing AI and machine learning? Big question, no pressure.
I don't know the answer, but I'm gonna maybe attempt to answer Uwe's question. How do I evaluate fairly that algorithm? And I would say with patient-relevant outcomes. If I'm able to demonstrate that, that classifier helps me, achieve better outcomes in terms of prognosis for my patients, again, in patient-relevant outcomes, I think we have a better way of assessing the classification power, the accuracy of an algorithm. And I think that's what we are advocating in this problem of overdiagnosis, labeling things as patients as disease when we don't really know whether they're diseased or not, giving that uncertainty that Uwe describes. If we add the prognosis of observation period, we could eventually come up with fairer evaluations of these algorithms.
So Daniel, if I can respond to that, I tend to agree with you, but I would imagine the public doesn't have that viewpoint. Because if you look at self-driving cars as a maybe slightly different example, they cause one accident, suddenly it's like, let's ban self-driving cars. Computers are not allowed to make any mistakes. That seems to be more the attitude of the public, right? So a small improvement would be acceptable, you say? I agree. But it seems the public says, oh, one mistake is one mistake too many.
Yes, and I think that's, I don't think that's specific to AI in particular. We're seeing that now with the COVID pandemic, how much, excess death are we willing to tolerate now with all the, letting the virus roam or locking everything up. And now the latest information about excess mortality shows that Australia actually decreased mortality during 2020 and 2021. So should we stay like this forever because, fewer people are dying? Again, I think that it's not a matter of a computer doing the decision, but it's actually somebody making an explicit changing the way that the natural order of things. I think that's the challenge comes from there. But yeah, I think that's a deeply complex problem, Uwe. I agree.
Okay, it seems to me very much we return again to this classic conundrum of the tension between innovation and regulation, sort of assessment and experimentation. And comments you made, Uwe, about wanting to assess the machine learning algorithm or the AI rather than the human, because there will be the human inevitably responsible if something goes wrong. That leads me to our second question, which I think is related to this. In which the questioner is asking, what would you say are the most common bottlenecks when applying AI for medical purposes, both from a technical side or the researcher's side? And this seems to me to be a question that's very much about whether or not there is over-regulation in some instances. I wonder if the panel have any thoughts on that question.
I have a few thoughts, but I don't want to monopolize the answers.
It was directed at you, Daniel.
Oh, okay.
There's a little at there, so
sorry,
feel free.
I didn't see that. Yeah, so we're starting to see regulation. I don't think we have an overly regulated environment at the moment, and in particular in Australia, the TGA explicitly defined decision support systems that are targeting clinicians. So where the decision is being made to support clinicians, that would be outside of the regulation. So again, I don't think we have an environment with too much regulation in terms of implementing these things. I think that the major barriers are collecting the right amount of data in a safe way that, is representative of the population, but on the other hand, that it's protective of patients' preferences in terms of privacy. The other one is, the messiness of the data. And the third one, I would say, creating these labels, which is how we train these systems, needs expert input. And that expert input it takes long, it's expensive, and it's not perfect, as Uwe just described. So those things are, barriers for, creating these systems. But then when you implement them, I would go back to the barriers that I described using my slides. You need to go back to an environment where the data is messy, where patients don't have a single clinical problem. They usually have multiple clinical problems that they interact with each other. And that's not usually what the algorithm was trained to do. And then when you have conflicting recommendations, what do you do?
Great, thank you, Daniel. I can see that the chat is on fire, which is fantastic. And the panelists are responding to people on the fly, which is very impressive. There's a question in the chat about the, I suppose, universal concept of fairness. And I think this is a really interesting point to pick up on, particularly since you were all speaking to automated decision-making in healthcare and yet come from different backgrounds. And so the questioner is saying that fairness is a difficult concept to define, but there seem to be some norms in every discipline or field of study. And they're interested in you sharing your thoughts on how you think your own fields, bioinformatics, data science, biomedicine, or practicing medicine in particular, define this concept of fairness compared to how you personally define fairness. So there's sort of two questions in one there. I'm interested to hear from all of you about whether you think your own field at a computational or practical level defines fairness differently for machine learning, And does that differ to how you would define fairness personally? Should I start with you, Wendy?
Sure. Well, that's a hard question because I want you to tell me what you mean by fairness, and then I'll say how our field addresses it. But that's the whole point, right? What is fair? I do think the discussion in the chat about relative risk and making sure that when we evaluate what we do, that we're putting it in the context of what the option is. That would be one thing that I would say is an important thing. Daniel?
Daniel?
Yeah, I'm thinking, I don't know if I have an answer. Usually in I would say in clinical medicine, we try to make, you know, patients part of this.
We can't hear you now, Daniel.
Oh, you've accidentally muted. Okay. Can I throw to you, Uwe, while we're but Daniel, you're on the spot.
Very good.
Question of fairness in a machine learning and computing context. Oh, okay, we can.
Now I can. Daniel, you want to continue? Yeah.
But you can hear me, so I can answer at least. So I would say that in clinical medicine, we tend to, you know, put the patient in this perspective of fairness because it's one of the, you know, the main ethical principles is the principle of justice. And that means, you know, providing equal access to fair services to everyone. So then, you know, if we take the patient's perspective, it becomes a little bit easier to understand whether a system is being fair in making its assessments. But again, we still haven't, I would say, we still haven't figured out what's a systematic way of doing it.
What I can say is, look, in machine learning, we're still mainly obsessed with statistical analysis of results, large data volumes, you know, this kind of scientific question, t-test, you know, we're on that angle mainly at the moment, which isn't great because I think we need to embrace the ambiguity that is there, and that hasn't really been done, and there isn't a great way at the moment to deal with the uncertainty and the ambiguity. So I haven't seen a good approach to that.
Okay, thank you. I think we got a lot there, and yet somehow more questions raised than answered, which speaks to the complexity of the concept of fairness for AI and decision making. There are quite a few questions coming through, but I'm just going to jump to one that I think is a little bit different to some of the other discussions we've been having. And this is about the strong case for use of AI in assimilating and interpreting data that helps patients decide whether to seek treatment or whether to adopt a watch and wait or watchful waiting position. So I suppose this is very much a question that is about using data and algorithms to put the power back in the hand of the patient, which in itself raises enormous ethical questions at a societal level, but for healthcare in particular. So from the panel, really curious to hear your thoughts on this and the direction that that's heading in your respective fields.
So I'm working with motor neuron disease patients at the moment, who one of the problems they have is they have difficulty breathing, so they're using ventilators. And they really could do with a lot of assistance to maybe adjust the ventilator, but in other areas too. So I'm very much on this wavelength of we should actually develop AI to help the patient. The difficulty, of course, is at the moment at least, it's quite a hard problem to solve. And what should we tell the patient? Like, if you do the knob on this setting, you have a 70% chance, and if you do the knob on that setting, you have an 80% chance. Can people understand that, or do we need the expert in the middle that can translate that a little bit? But I like the idea.
That. Yeah, that's a really great point, Uwe. And I was thinking about some work we've been doing on virtual care and what patients want to see in virtual care in the future with, you know, home monitoring, remote monitoring things. And one of the main things that they want is they want the provider in the loop. They want to know that their physician or nurse is looking at their data and giving them feedback when they need it.
Daniel?
And I think I think, we are being, as clinicians, we're being challenged into how to include patients in, in this loop constantly. Now we have methods of collecting data between patient visits. But yesterday I attended a workshop on to try to design a new system to monitor patients with cancer. And I would say that overwhelmingly clinicians said, I don't want to see patients' data between visits because I don't have time. That's not my job. And so again, having these tools, do part of the work of understanding what's meaningful information and what's not meaningful information. I think it's a space where we can definitely make contributions from this field of health informatics. But again, there's a balance between overwhelming patients and clinicians with too much information that they don't know how to action upon.
Do you think in relation to that, and this is something again for all of the panelists, and is something I think we keep coming back to across the areas of bias, translation, interpretation, as AI plays an even greater role in healthcare, and as the amount of data and the ways in which we can analyze that data in healthcare continue to, I suppose, accelerate, do you think there's need for a greater interpretative role from other fields, perhaps into this space, to help bridge that big gap between patient and practitioner or doctor and clinician and so on? Do you think that the complexity of the data systems have taken a turn in which we need to return to first principles and find new ways of bridging the informational gap, so to speak? And if so, what form could that possibly take that would be useful for people?
So in my case, I think that this, the ability to synthesize information, it's a great skill that most information systems applied to healthcare lack. And I think clinicians would love something like that. We spend a lot of time trying to understand who the patient is, why the patient is coming to see me, what's their past medical history. Having a synthesis of who a patient is, and maybe having the patient being able to contribute to that synthesis is a great space where technology can play a very important role. And that involves this automated synthesis will involve artificial intelligence agents that are able to do that. We're not there yet, but I think that's one space where you're not necessarily giving them these entities that the power to make all the decisions, but synthesizing information in a meaningful way and communicating it in a meaningful way should facilitate that clinicians and patients spend time doing what they do best.
Absolutely. And I think it speaks to, again, in the chat, this is just coming up on this topic, the concept of trust and what trust means in a contemporary milieu in which patients may feel as though they're beginning to lose control of understanding the amount of data that's available and when that data ends up in other hands. I want to end, just because we have 2 minutes left, to throw it back to you as the panelists. Any final closing thoughts, comments, ambitious statements about the future of automated decision-making in healthcare that you'd like to leave our audience with?
Okay, well, I'll start, and this is spurred from the conversation in the chat and about the human in the loop. So I think a lot of these things are this partnership between AI and the physician and the patient. But I also think with the explosion of data, and as we get more genomic data and environmental data and all kinds of data, the human just can't handle it all. And there's a role for closed loop systems where the machine is making the decisions. And there are examples of that in the ICU, especially, where you can demonstrate that you get much better outcomes for patients if you let the computer do the work. And so we need to be open to that.
Fabulous. Thanks, Wendy. Uwe and Daniel, Closing remarks.
Okay, well, I would say it's all about education. We need to educate more people how AI actually really works, and then people can challenge all these things themselves.
Yes, and my final statement would be, are my patients better? If we are able to demonstrate that, as Wendy said, including these closed loop systems and letting the computer make decisions, I can demonstrate that patients are better, why not adopt them?
Fantastic. That was such a compelling series of statements to conclude on. We've more or less written a PhD in the chat today, so I will be keeping that because there's a lot of fascinating information in there. Thank you to our panelists today, Uwe Aickelin, Daniel Capurro, and Wendy Chapman. It's been a fantastic panel. I really appreciate your thoughts and generosity in sharing your experience and research with us. Thank you to CADE and the Centre for the Digital Transformation of Health, and to all of you for coming along. Stay tuned for our next panel in this series, Technology and the World Around Us, and take care.
Thank you so much.
Bye all. Thank you.
So much fun.
Bye.
Bye.